Thank you for joining Cancer Support Community Atlanta for Frankly Speaking about Cancer Risk Among African Americans, facilitated by Dr. Ryland Gore with North Atlanta Breast Care. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs.
We look forward to your questions. We look forward to your input as we go throughout this presentation. So without further ado, of note, I want to make it clear these following slides were medically reviewed and validated via an outside source earlier this year, and all of the information is up to date. So people always say, why does this matter? Why does this matter? I think in the current context of coronavirus specifically is very important because we know that certain diseases affect us disproportionately, including coronavirus with, the number of new cases and the number of deaths, but also as it relates to this program, cancer. Over 200,000 new cancer cases were diagnosed in the African American community in 2019. And I think it's very important to note that African Americans have the highest death rates and the shortest survival time, meaning the lowest survival rates amongst those that are diagnosed with cancer in the United States. The most common cancers among Black men are prostate cancers, lung cancer, and then colorectal cancer. The same for Black women. We're most likely to be diagnosed with breast cancer and then lung and colorectal cancer. When you look at breast cancer, prostate cancer, lung cancer, and colorectal cancer, these cancers constitute greater than 50% of the cancer cases we see in the African American community, so an overwhelming majority. This graph, I know there's a whole lot going on this graph, but this graph shows that, again, what I just stated, new cancer cases in males, number one, prostate, over 30% of cases, lung, and then colorectal. And for females, breast, lung, and then colorectal. Regarding cancer deaths, it's across the world. It doesn't matter if you're Black, white, worldwide, lung cancer constitutes the number one cause of cancer deaths. And then prostate for men, breast for women, and then colorectal. But I want to give you guys some new data. I've been doing a lot of volunteer work with the American Cancer Society as I've been involved with making strides against breast cancer. And breast in the Black female is actually the number one cause of cancer deaths in 6 states. Yep, we're looking at one of them, Georgia. So in Georgia and 5 other states, those states are Arizona, Colorado, Florida, Mississippi, and South Carolina. Breast cancer is actually the leading cause of cancer deaths in Black women. So this is something that we should absolutely take seriously, and it's something I take seriously with my patients. This is just another graph to kind of show you the schematics regarding death rates for cancer amongst Blacks and whites. Again, it looks nice. All of the curves are downtrending. So basically, the number of cases that are being diagnosed, the number of deaths that are happening is decreasing, but it's still affecting African Americans disproportionately for those major cancers that I discussed in the previous slides. So why do these disparities exist? I think that this is completely multifactorial, and there are whole, departments committed to trying to figure out why these disparities exist. I think a big one, especially in a state like Georgia, lack of access to quality health care. I think the same can be said for other southern states and states that have very high, very large rural population. If resources are spread out, if health centers are spread out, then it becomes a problem. It becomes very difficult to access quality health care and access quality physicians. Health insurance status. Unfortunately, African Americans and people of color are more likely to be uninsured or underinsured. But what I find very interesting actually is a lot of the disparities research that has been done demonstrates that even when you control for insurance status, that African Americans still fare way worse than their white counterparts. Of course, we have to worry about discrimination. Again, a lot of disparities research, something that I'm very highly interested in, has demonstrated that across the board, as it relates from screening to treatment, African Americans are more likely to receive substandard care, which is obviously a problem, which is why I also advocate very strongly for graduating more physicians who are people of color, not just African American, but all people of color could benefit from having physicians that look like them and can relate to their particular struggles. Education. The lower your education level, the more likely you are to suffer from certain health disparities. But I would go even a step further and say not just education, because we all know people who are smart who may not have necessarily gone to college, but health literacy and actually understanding health information so that you can make a very reasonable and educated decision regarding your health choices. Some things you can't control, such as housing and exposure to environmental pollutants, and that's also a very touchy subject. Access to healthy foods and obesity. There's a whole lot to be said for that as well. We live in certain areas, and I've seen it here, even in the metro Atlanta area, where you have places that are food deserts, meaning they may not have grocery stores for miles. If there is a store, it's usually a bodega or a corner store that may not necessarily have access to fresh fruits and vegetables. And then, of course, that's a discussion on its own when you think about the cost of fresh fruits and vegetables. And it's way cheaper, to go to McDonald's than it is to buy fruits and vegetables for your family. There are certain things that you guys just cannot control. And number one, that's basic biology, your family history, genetics. If there are genetic mutations in your family that you are aware of, this will increase your risk for certain cancers. And it has nothing to do with you. It's just the way your body works and the way your genes are set up. And then lastly, decreased access to cancer clinical trials and a historical lack of representation of African Americans in clinical trials. I think this is actually a very touchy subject considering the history in this country. I'm just going to start by saying a lot of my opinions, some of my opinions you hear today will not reflect the opinions of the cancer support community, and definitely will not reflect the opinions of the Northside Hospital Cancer Institute. But there are a lot of things that we often don't say that deserve to be spoken out loud. And so as it relates to clinical trials and the representation of African Americans and other people of color in clinical trials, we all know that this country has a very touchy history with that. And I think that most people, at least older Black Americans, remember the Tuskegee syphilis clinical trials. And then, of course, in North Carolina in the 60s and 70s, there was sterilization of African American women. And so it's a very touchy subject, but I will say that I think it's so important for our people to participate in these trials so that we can know how we respond to certain treatments, and also so that we have access to certain treatments that will extend our life expectancy. So there, I'm off my soapbox, y'all. So let's start to talk about prostate cancer in our African American males. Again, this is the most commonly diagnosed cancer in African American males and the second leading cause of cancer deaths in African American males. We are more likely to be diagnosed. You are more likely to be diagnosed with prostate cancer at a younger age, so younger than the age of 50. I personally have people in my life who were diagnosed with prostate cancer in their early 40s and mid 40s, so this is very real. And if you look at the graphic on the left side, it basically shows that as you increase in age, you're more likely to be diagnosed with prostate cancer. As is the case with most cancers, cancers are diseases of aging. The older you are, the more likely you are to be diagnosed. But specifically for Black men, 1 in 5 Black men, point blank period, doesn't matter how much money you make, doesn't matter, your insurance status, none of that matters. 1 in 5 Black men will be diagnosed with prostate cancer, period. As is the case with most cancers, there usually isn't a warning sign. But if a man were to experience symptoms, he may experience increased frequency of urination, especially during the night. If there's a difficulty with starting your urine stream, difficulty with stopping your urine stream, if you have pain or burning with urination, weak flow while you're urinating, Obviously, pain with sexual intercourse. I know some people don't like to talk about it, but it's very real. And sexual health during cancer care is actually a very important topic that I'm also very passionate about. If there's a difficulty with an erection, painful erections, painful ejaculations, pain, pressure in the lower back or in the rectum, these are problems, and these things deserve to be addressed with your urologist or your primary care physician. How do we screen for prostate cancer? It's a blood test, the PSA test, which stands for prostate-specific antigen. This is produced by cells in the prostate gland. Normal cells produce it as well as cancer cells, and we like to measure your PSA levels in your blood. So the common question is, so what's the normal PSA level? We like to see that less than 4.0, less than 4 nanograms per milliliter. Obviously, you can have a higher, if you have a higher PSA level, that doesn't mean you have cancer. And just because you have a low one, that doesn't mean you don't have cancer. So this is a discussion that you need to have with your primary care physician. And it's very, very, very important. Now, that goes without saying that there are conditions where your PSA level will be elevated, and it doesn't mean you have prostate cancer. For example, say you've had a recent hospitalization and for whatever reason, maybe you had surgery or whatever, and you needed to have a catheter placed, or there's been some kind of manipulation of that area. Well, your PSA level is going to be increased because the prostate was stimulated. If you've had a UTI, if you've had any kind of inflammation of the prostate or inflammation of the bladder, these are all things that can cause the PSA levels to go up. And so if that's the case, then after these conditions or after the Foley catheter is removed or whatever, you need to wait a certain amount of time, at least 2 to 4 weeks before having that PSA level checked to make sure that it goes down appropriately and so that you don't have a false positive test. One major concern with prostate cancer screenings and most screenings is, well, why are we screening everybody? If you screen everybody, then of course you're going to find more things that you weren't necessarily looking for. What if we never checked, it never would have led to cancer, it never would have led to death, or never would have led to a big situation and unnecessary treatments? I'm just going to go off the record and say that this is a very personal decision, but when it comes to screening and when it comes to figuring out what's important to you, only the patient can determine what is important to them. And so for a lot of people, having another 10 years or even 5 years, a lot of the recommendations say, well, if the patient's lifespan is probably less than 10 years, it might not be worth it. But again, a very personal decision when you start talking about screening. And so I always recommend that patients go to their primary care physician if they have any questions or issues with this. As I stated previously, some studies have shown that even when we screen, when we do mass screenings, it doesn't necessarily reduce a man's chance of dying. Of course, it can lead to false positive results and lead to more tests. And this can obviously cause anxiety with patients wondering, what's going to happen? Do I actually have cancer? Now I got to figure out how to get to the doctor. Now I have to pay more money. Now I have to do all these extra things that I probably wouldn't have had to do if I didn't do this test. Well, I think it's very important. But again, only the patient can determine what matters to them and what they value. And so if knowing what's going to happen so that you have an extra 5 years or 10 years with your family is important to you, then that's what it is, and we should move forward. If you know that regardless of the test result, you're not going to do anything in the first place, then maybe it's not as important to you. But again, a discussion to be had in conjunction with your family and in conjunction with a physician you trust. And of course, as with most things, if you require biopsies because of an elevated PSA, this can lead to other issues. But when it's that time, and if you need additional testing, of course, it's incumbent on the physician taking care of you to let you know of all of those risks as a result of additional testing, including incontinence, including pain, impotence, all of these things that could affect your quality of life. So what are the screening recommendations? I'm just going to go and say off the bat, I think the United States Preventive Services Task Force in general, I think their screening recommendations are trash, and I don't know a single physician that does oncology care that follows their recommendations, because they never hit the mark, to be completely honest. But regarding PSA screening, they recommend that men ages 55 through 69 have a discussion with their doctor and talk about the risks versus the benefits of screening for prostate cancer. And if you're over 70, hang it up. They don't want you to do any PSA screening. The American Cancer Society, they are way more reasonable and recommend that men 50 or over who are average risk and have, a planned lifespan of at least 10 years, that they have a discussion. But Black men, there's nothing ordinary about you in every level, and I mean that in such an amazing and good way, but unfortunately, you are considered high risk. And so those recommendations don't even apply to you. So Black men, starting at the age of 45, by virtue of being Black, you are considered high risk for developing prostate cancer. And we discussed this earlier when we talked about the death rates and the rates of new cases. Also, if you have a first-degree relative with prostate cancer, you are considered high risk. And so you should be having a discussion regarding screening for prostate cancer. God forbid you have more than one family member who's a first-degree relative, or you have a first-degree and a second-degree relative who had prostate cancer, you're even higher risk. And starting at age 40, you should have screening started. And again, like I mentioned, I know too many men who were between the ages of 40 and 45 who are Black men who've been diagnosed and had to undergo treatment for prostate cancer. So this is very real. And there's another subgroup on here that isn't mentioned, but when we look at people who have genetic mutations, if you have a genetic mutation or know of it running in your family, the BRCA gene, that's the breast cancer gene, BRCA1, BRCA2. We usually look at it in the setting of breast and ovarian cancer, but men who have a BRCA genetic mutation are also at risk for male breast cancer. That's number one. Yes, men do get breast cancer, but also prostate cancer. You're at increased risk for prostate cancer. And so if you know that you have a BRCA gene mutation, another one that increases your risk is an ATM, like an ATM where you get money, an ATM gene mutation, and the CHEK1 mutation. If you have any of these genetic mutations in your family, you're also considered high risk, and you should start screening sooner than what was mentioned in the previous slide. Let's switch gears to breast cancer. Obviously something I have devoted most of my life and my work to breast cancer and treating breast cancer patients. And so obviously this is something I feel super passionate about. As we discussed, amongst all women, it's the second leading cause of cancer death, but in 6 states. And I mentioned those 6 states previously. Remember, Arizona, Colorado, Florida, Georgia, Mississippi, and South Carolina. Breast cancer, unfortunately, is the leading cause of cancer deaths amongst Black women. So this is very serious. Black women are more likely to develop breast cancer at a younger age. Usually we say, 50s, 60s, 70s, and actually a woman is most likely to be diagnosed after the age of 50. But Black women, we're more likely to be under the age of 40 when we are diagnosed, 2 times more likely. And we are more likely to have more aggressive forms of breast cancer. And I'm specifically thinking about triple negative breast cancer. You may have heard of this, but what that basically means is your cancer doesn't express the female hormones, estrogen and progesterone, and it doesn't express another receptor called HER2. And that's the human epidermal growth factor receptor 2. If you are negative for all of these things, do not pass go, do not collect 200. We are worried about you. And unfortunately, you are more likely to see this type of cancer in African-American women and young women. Risk factors. There are certain things that you cannot control as it relates to breast cancer. For example, your age. You heard me mention previously that most cancers, unfortunately, are diseases of aging. As it relates to breast cancer, main 2 risks: being a woman, because the overwhelming majority of breast cancers rely on our female hormones for growth. Being a woman and living long enough to see it develop. Those are your biggest risk factors. I see dense breasts on here, and a lot of women come into the office and they're so concerned and they say, my breasts are super dense, I'm gonna get breast cancer. Well, not necessarily. The risk lies in that the more dense the breast tissue is, especially young women, the harder it is to see abnormalities on the mammogram. And I've seen mammograms of these women with dense breasts, and it literally, everything looks white. Remember, what looks white on an x-ray? Bone, very dense, right? Women who have a lot of breast tissue, everything looks white. So it makes it much harder to identify abnormalities. And so the risk isn't in the dense breast itself. The risk is there because of the increased difficulty of reading the mammogram. And with dense breasts, mammogram can miss up to 30% of new breast cancers. If you have a family history of breast cancer, I have quite a few women in my practice who literally every single woman in the family develops breast cancer, but they've undergone genetic testing and they don't have any genetic abnormalities. You're still at risk, period. It doesn't matter that the genetic testing is negative. You're still considered high risk. And of course, genetic mutations will increase your risk. For example, I discussed BRCA1 and BRCA2 as it relates to prostate cancer risk, but women who have a BRCA mutation, lifetime risk, 85, upwards of 90%. You are guaranteed to get a breast cancer diagnosis. And of course, this increases your risk of ovarian cancer as well. Previous radiation, we don't see this as much anymore, but people who've had childhood lymphomas, mantle cell lymphoma, the most common treatment was radiation to the entire chest. And when you do that, especially in these young patients, you increase their risk for a future cancer diagnosis in the future. And that's the same, that's for breast cancer and also actually lung cancer with that radiation exposure at such a young age. Your menstrual cycle. Some people say, what does my cycle have to do with this? Anytime you have a very, very long period of exposure to estrogen and progesterone, the female hormones, you increase your risk. So those women who got their periods before the age of 12, I know some people who started as early as 8 or 9, or you go into very late menopause, meaning 50s or maybe even early 60s. That's a very long time of almost continuous estrogen and progesterone exposure. And then this, of course, increases your risk of breast cancer. One thing you don't hear about often is diethylstilbestrol. This was a drug that was used in the 50s and 60s for women who were at risk of preterm delivery, and so they were given this synthetic estrogen. But what we know now is that the daughters of those women have increased risk of breast cancer, but there's another cancer, clear cell adenocarcinoma of the vagina, which is number 1. These are starting to decrease, obviously, as we don't give that drug anymore now that we know the side effects, but something to be mindful of. There are some things that you can attempt to control. People always are yelling at us about being overweight and obese. And I think, body habits and just the build of our bodies has a lot to do with it. So I'll be completely honest in that sometimes I don't think the BMI is fair to people of color, to be completely honest. But it's still important to note that we have to take care of ourselves and we have to have a healthy weight, especially after menopause. One thing that people don't know and don't really recognize is that fat is the largest storage space for estrogen. Our bodies are very tricky, and I explain this all the time to my breast cancer patients. After menopause, the ovaries are no longer the primary source of estrogen and progesterone. So your body is able to turn your fat cells and hormones from your adrenal glands into estrogen and progesterone. Ain't that something? That's very tricky. And so if you're overweight and you're carrying a lot of weight and carrying a lot of fat, especially centrally, this can become a serious issue. So it goes without saying that trying to eat a healthy and balanced diet is very important, not just for breast cancer, but for many of the other cancers that we are afflicted with. Alcohol intake. Y'all, I enjoy a nice glass of wine, like most of us. I know some of y'all are trapped in quarantine with your kids, and Cabernet and Chardonnay are helping y'all get through some of these crazy days, but you got to slow it down. First of all, no binge drinking, certainly no 2, 3, 4, 5, 6 drinks at any one sitting every single day. But what we do know now with our breast cancer research is that regular alcohol intake, more than 2 drinks per day, doubles your risk of developing breast cancer. And so if you had any reason to cut back, even though, quarantine is probably driving you crazy, this is one of them. Alcohol has been associated with many cancers, including breast cancer, and as we'll talk about soon, colon cancer. Physical activity is very important. I encourage with maintaining a healthy weight, decreasing the fat, and I encourage patients at least 20 to 30 minutes of physical activity 3 to 5 times per week, and you'll begin to see changes in your body that are very positive, but you also will cut your risk of developing cancer. Birth control pills, obviously evening out estrogen levels, progesterone levels will decrease your risk of breast cancer. For the women in here who have never been pregnant, you don't want kids, only want 1 kid, pregnancy actually helps with minimizing your estrogen exposure. And so obviously women who have more kids, they drastically decrease their risk. If they breastfeed, they decrease their risk of developing breast cancer. Nulliparous, or women who have no children, are at higher risk of developing breast cancer because of the continuous estrogen exposure. And then, of course, hormonal therapy. This is something that I completely have to double down on. I know that after menopause, it's rough. Hot flashes, irritability, all those things that estrogen helped control. But I have quite a few women in my practice, my cute little old ladies who are 60, 70, even 80, who have been on continuous hormone replacement therapy for 20, 30 years. This one woman told me 30 years of continuous hormone therapy, and they all developed these little small breast cancers that are very strongly estrogen positive and progesterone positive. And we can almost always say without any doubts in our mind that it was because of the hormonal therapy. And so I strongly encourage people, if you need a little something to get you through the first couple months, that's great. And I have no problem with that. But this is not something that should be on continuously, and certainly not for a super long period of time. I've kind of beat this over the head, but again, there are disparities in all cancers, but especially in breast cancer. African American women more likely to be diagnosed at advanced stages. They will experience treatment delays, starting treatment, continuing treatment, and then the follow-up that comes along with that. We have similar rates of being diagnosed with breast cancer as white women, but we have a 40% higher mortality rate. We're 4 times more likely to die than white women, and certainly Hispanic women or Asian Pacific Islander women. And this has to do with so many things: comorbidities that we already have, other health issues, being diagnosed at a later stage, screening and making sure we tap into screening. There are so many studies that show that stage for stage, we always do worse. Even for those cancers that are considered highly treatable and good cancers, we do worse than our white counterparts. And then when you look at the entire process as it relates to screening all the way to treatment and survivorship, there are disparities in cancer care. And so this is something that I'm actively working on to minimize that gap and strongly advocate for my patients. Signs and symptoms. As with most cancers, you usually don't have signs or symptoms. And I tell my patients, if you feel something, we're already too late. One thing that mammogram has shown us, I'm so proud of just the huge strides we've made in the last 20 years with screening mammograms. Screening mammograms can pick up on a cancer up to 2 years before you can even feel it. That's a long time for something to develop. I have patients who come in and they say crazy things to me. I have been feeling this mass for 2 years. It didn't go away, but I wasn't going to do anything. Wait, what? No, no. If you can feel something, it's already too late. Obviously, the training is, and what we're taught in school is, breast cancer is not painful. Well, after a certain point, if it gets too large, it is going to become painful. And certainly if it's grown so large that you have wound care issues, it is certainly painful. Other symptoms that you should be mindful of, that you should really pay attention to, any kind of skin changes in the breast. I've had women who've had, dimpling, nipple retraction, the nipple pulled completely inwards, thickening of the skin. The breast starts to look like an orange peel. It's red, it's tough, it's thick. Sometimes there's breast contraction and the breast has become much smaller than the normal breast. All of these are problems, and these are possibly indicators of advanced disease. Not to say that redness or whatever can't happen with other issues. Some women have mastitis, but if you're an older woman, you haven't recently had a baby, you're not breastfeeding, and then all of a sudden you have these crazy skin changes, the breast is red, the breast is swollen, the breast is super painful, ma'am, that's not a breast infection, okay? And it's certainly within the standard of care to give you antibiotics, but there are certain things that antibiotics won't fix. So I know people love antibiotics, but I just want to say they don't fix everything, and it certainly doesn't fix a breast cancer. And so if you experience any of these changes, you need to be seen. I don't care if it's not me, you need to be seen by somebody immediately so that these things can be taken care of. As I mentioned, mammography is the best screening tool we have, and over time, our technology has improved wonderfully. And I know for a fact that we have a great team within the Northside Cancer Institute and just great technology that allows us to take beautiful pictures and really hone in on what's going on with our patients. Common question that I get regarding screening: well, doc, should I get a 2D mammogram or a 3D mammogram? I love the 3D mammogram, and in certain places where I've been, for example, New York, it's covered by insurance. I know that certain other states are a little bit slow in taking this up regarding taking care of that cost. But the good thing about 3D mammogram, I know that's not on this slide, but it is a common question. The good thing about it is that we're able to get 3D reconstructed views of the breast. And so especially if you have dense breasts, it makes it much easier for the radiologist to see what's going on and say, oh, that's not anything, that's a cyst, or oh, that's just some kind of thickened tissue, but this doesn't look abnormal. It allows us to do that and totally decreases callbacks and decreases biopsies, things that women worry about. And so if ever you're able to get a 3D mammogram or it's offered to you, I always tell patients that it's a good idea. But if you can't, that's fine. And 2D mammogram is still just as fine, as long as you're getting your mammogram every year. Everybody's not going to agree with me. I know the United States Preventative Task Force, or whatever that long name, they're not going to agree with me either, but I believe in mammograms every year. One thing, huge controversy: well, we're screening everybody now starting at 40, and now we're finding a bunch of cancers. Yeah, that's the point. Of course you're going to find more cancers, but the issue is that some professionals believe that we are finding cancers that may not have ever posed a problem. And so they once again, just like prostate cancer, they feel like we are overdiagnosing and overtreating. Again, very personal decision, but if somebody told me I have cancer, there's no such thing as an overdiagnosis. I'm trying to stay alive for my family, and there's a lot of life to live and a whole lot to do. And so again, this is very subjective, whether something is an overdiagnosis or an overtreatment. But I think it's very important, and the whole point of a screening test, not just a mammogram, but all of these screening tests, is to find issues before they become a problem. And so another common question, I'm gonna just nip this in the bud right now. I don't like mammograms, they hurt, why are y'all squeezing my boobs, and rah, rah, rah. Guess what? You need a mammogram. Some patients prefer an ultrasound, which is fine. And especially for my women with very dense breasts, ultrasound is a great adjunct to mammogram to look for certain things that we may not necessarily see on mammogram. So mammograms are going to show us calcifications, especially calcifications that are considered malignant. It's going to show us distortion in the breast tissue. There are certain things that we see on mammogram that we could never see on ultrasound. Sometimes patients' mammograms look completely fine, and then you get an ultrasound, and it's like Mayday. Ultrasounds are going to show us masses, specifically whether they are cysts or solid masses that we don't necessarily see on a mammogram because the breast tissue hides them. And so these things are used in conjunction, not in replacement of. And so regardless, if you're a primary care physician or you're a breast surgeon, if they're doing the right thing, they're going to order a mammogram first. Screening recommendations. Again, these are not, this is not my belief, but United States Preventative Services Task Force recommends that women 40 to 49 begin to have a discussion with their primary care physician or whoever regarding whether they should start screening during this time period, and from 50 to 74 every other year. American Cancer Society, starting from ages 40 to 44, you have the option to screen every year. 45 to 54, you screen every year, hands down. And then 55 and older, this can be a discussion where you switch to every other year versus yearly. And then there's the belief across the board for all of these organizations that after the age of 70, I guess magically you about to die in 2 years, and so you don't need screening. I know plenty of people who are so vital and are living through their 80s and their 90s, very active, and have social lives, like better social life than I have sometimes. And so I don't necessarily agree with stopping screening at 70 years old. I think if that person has a reasonable chance of having a fulfilling life, even if for them that means 2 to 3 years instead of 10 to 15 years, then it's worth it to get screening. So I'm just going to let the record show, especially with Black women, we're having a discussion about cancer risk in the Black community, especially with Black women more likely to be diagnosed at younger ages, under the age of 40, at least 2 times more likely to be diagnosed under the age of 40. And then in my practice, I have women in their 20s. The youngest one is 24 with a breast cancer diagnosis. You absolutely should be starting your screening, point blank period, at 40 years old. And that is Dr. G's shameless plug for screening mammograms. Who is considered high risk? Strong family history. Again, I've mentioned there are some families where everybody ends up with some sort of cancer and they've gotten genetic testing the way they're supposed to, and the genetic testing is negative. You're still considered high risk, and you should be getting screening and having a discussion about enhanced surveillance. If you have a known genetic mutation, not just BRCA, but so there's BRCA1 and BRCA2, but there is the PALB2 mutation. There is something called the RAD51 mutation, ATM mutation, which we briefly talked about with prostate cancer as well, CHEK1 mutation, and certain other mutations that increase your risk, then you should be getting enhanced surveillance. And of course, chest radiation, as we mentioned previously, in your childhood. So what does enhanced surveillance mean? For my patients who are super high risk, this means every 6 months alternating an MRI and a mammogram. This says starting at age 30, but I'll be completely honest, especially my women who are BRCA, known genetic mutation, or other super high risk features, a lot of them are starting in their 20s with this. And sometimes it takes work, but I am able to usually get it approved by insurance. And then this is something that's controversial, monthly breast self-examination. There are some people, American Cancer Society has stated in their recommendations that this is not recommended. Other governing bodies have stated it is not recommended. But I tell my patients, is it foolproof? No. But I think it's very important for patients to know the land, know the lay of the land. You should know your body, and you should know what's going on with you before you come to the doctor's office. You're going to know way more than I am. I'm a stranger, but you are not a stranger to yourself. And so you should know what's going on, so that if something weird pops up, whether it's a weird pain or a new mass or whatever, you need to know. I have some patients who come into my office and say, hey, I know my breasts are lumpy bumpy, but this is not normal, and this is not what I normally deal with. And so being able to vocalize that and you're not going to always have a physician that advocates for you. And so knowing how to advocate for yourself is very important. So I just want to make sure I say that out loud. Lung cancer. Once again, y'all, you already know the drill. African Americans are more likely to be diagnosed. Black men, you especially, 15% more likely to get lung cancer than white men. Black women are actually diagnosed a little bit less than white women, but again, something that is disproportionately affecting us. The major risk factors: smoking, smoking, smoking. Put those cools down. Put those Newports down. Don't do it. It stinks. It makes your breath stink. And smoking has been known to contribute to greater than 80% of lung cancer cases. About 7% of cases are attributed to people who are non-smokers who have had exposure to secondhand smoke. So for yourself and for the people you love around you, let it go. It's an expensive habit too. Please just let it go. There are other things. Asbestos, not so much. I remember for a long time, I remember being a little girl and seeing those mesothelioma commercials on TV all the time due to asbestos. But I think that has gone down in more recent years. Workplace exposures for my people who are factory workers and do that kind of work. Please be mindful of your work environment and OSHA standards, and making sure that you have whatever protective equipment you need. I know that's become a huge bullet point over the last 2 months, but making sure you have the appropriate workplace protective equipment you need to keep yourself as safe as possible. Air pollution, of course, contributes to lung cancer. Arsenic in drinking water. This isn't really a big thing in most urban areas with appropriate water treatment plants, but this becomes a big issue for people in rural areas who drink well water. There is elevated levels of arsenic in the drinking water, so something to be mindful of. Again, like I mentioned previously, being treated with radiation therapy before, and of course, a personal or family history of lung cancer can increase your risk, and so that you should be mindful of this. Symptoms of lung cancer. Again, lung cancer is scary because for a long time, the overwhelming majority of people are diagnosed stage 3 and stage 4 because you have no symptoms until it really becomes a thing or has already spread to other areas. But weight loss is always a thing with any kind of cancer. Persistent cough. I know you guys are reading this and you're like, these symptoms sound like the corona. Don't worry about that. It goes with lung cancer too. I know I was thinking it when I saw these. Shortness of breath, changes in your voice or being hoarse, harsh sounds with each breath, coughing up a lot of saliva, coughing up large levels of mucus, a change in the color, the volume, the smell of the mucus. These are all big issues. Recurrent lung problems. I knew somebody not too long ago who was diagnosed with lung cancer. Every single winter, they would get, random sniffles or colds like most people, the common cold, but their colds would last for weeks and weeks and weeks and weeks. If there are certain things that just don't seem right, coughing up blood, mucus tinged with blood, these are things that warrant some sort of workup. Screening recommendations. And so across the board, I do agree with these. I know I've been talking trash about the United States Preventative Services Task Force for this whole presentation, but I'm not talking trash right now. Annual screening with low-dose computed tomography, so a CT scan in adults who have at least a 30-pack year of smoking or who currently smoke at all, or if you've quit within the last 15 years, is very important. And the American Cancer Society has the same recommendations. The low-dose CT has been vital and has changed the game regarding lung cancer screening. Back in the day, and certainly when I was in medical school, there was no such thing as lung cancer screening. It just didn't happen. And so this is a huge change and a win for the medical community and my colleagues who are thoracic surgeons who feel very strongly about this. Some people wonder, how much radiation am I going to be exposed to with this CT scan? So the low dose CT scan your exposure, I know this isn't on here, but some people like to know because they say things like, oh, I'm gonna get a CT scan and y'all are giving me cancer. Well, no, we're not giving you cancer. The radiation exposure is approximately 1.4, 1.5 millisieverts. Millisieverts is what we use to gauge radiation exposure. That's the measurement. A chest x-ray, usually 0.1 to 0.3 millisieverts, so very, very low dose. A standard CT scan, just the CT chest, 14 to 15 millisieverts. And so this is very low dose. You get exposed to at least between 3 to 4 millisieverts per year just by walking around the earth and simply existing. And so it truly is a low dose. And the benefits of getting this screening test outweigh the risks, in my opinion, especially since the advent of this mortality, this low dose CT scans has decreased the mortality from lung cancer by 20%. And that's because we're catching lung cancers at very early stages, stage 1 and stage 2 versus late stage 3 and stage 4. Colorectal cancer, again, as you've seen, we're more likely to be diagnosed with colorectal cancer. We're more likely to die from colorectal cancer. It's the number 3 cause of cancer deaths among Black men and Black women. Almost 20,000 cases diagnosed in 2019. We'll see what that number is for this year. Across the board, the rates of diagnosis has decreased, but still less so among Blacks compared to our white counterparts. I think a lot of this has been acceptance of, the screening modalities we have in place to catch colorectal cancer early. Once again, usually you might not always get signs and symptoms. I think I will say this: patients are more likely to have symptoms from colon cancer when it's a left-sided colon mass, so the descending colon versus the right side, versus the right-sided colon masses, so closest to the small intestine. If you are to have symptoms, you may notice that your stools are narrower than normal. We pencil thin. When they get like that and they're normally a normal size like a banana, you need to be worried. Abdominal pain, abnormal abdominal cramping, anemia. With colorectal cancer, you do lose blood very slowly through the colon. So if there's anemia or symptoms of anemia that are abnormal and you didn't experience that before, colonoscopy is one of the first things we do to check. Again, as most cancers are diseases of aging people in general. So your risk of developing colon cancer increases as you get older. A lot of the same risk factors for the other cancers are the same for colon cancer, specifically being overweight or obese, and physical inactivity and heavy alcohol use. Smoking has been associated with colorectal cancer as well. Red meat, lots of red meat. We love to grill, and how we cook our meat. We love to grill and do all of these things, but this can increase some of the toxins in our meat and increase our risk of colon cancer. There are certain things that you simply cannot control. There are a number of people who have inflammatory bowel disease, and so that's your ulcerative colitis and Crohn's disease. If you are affected by these, you do have an increased risk of developing colorectal cancer, and you should undergo the appropriate screening, and you will anyway. Your GI doctor or colorectal surgeon will be doing that anyway to monitor the progress of your disease from the inflammatory bowel disease aspect, but they'll be keeping an eye on you to make sure that you don't develop colorectal cancer as well. There are some families and there are some genetic syndromes where you are at an increased risk of developing high levels of polyps in the colon. I think of Lynch syndrome, familial adenomatous polyposis. If you have any of these genetic mutations, or you get colon cancer early, or it's not expected, and they do genetic testing on your tumor and find that you have these, it's something to be mindful of and something to make sure your family knows about. And of course, having type 2 diabetes, increased insulin resistance, it upregulates certain insulin receptors that are found in the colon and can increase your risk of developing breast cancer. So something to be mindful of. So for those of my some of our followers on here who have other illnesses such as type 2 diabetes, making sure you maintain glycemic control. The screenings, this has changed for the better, and I'm so happy about that. Again, United States Preventive Services Task Force, it's kind of trash as it relates to the African American community. The standard teaching has always been starting at 50, get your colonoscopy. Well, we know that African Americans are more likely to be diagnosed at a younger age. And honestly, during residency, I operated on somebody who was in their 20s who had colon cancer. And I just heard of one of my colleagues who diagnosed somebody who was 19 years old with colon cancer. So it's very real. The recommendations from the American Cancer Society and from the American Society for Gastrointestinal Endoscopy, especially as it relates to African Americans, is that we begin our screening colonoscopies, our screening, our whatever screening you do at the age of 45. There are multiple tests on the market now. There are some people who have lots of reservations about doing a colonoscopy, the prep that's required, the time off from work, recovering from anesthesia if you require anesthesia during a colonoscopy. There are a lot of concerns about that, but I will say that it is the gold standard. You see so many other tests listed here, the CT colonography, flexible sigmoidoscopy of note, that is direct visualization. It's similar to a colonoscopy, but it only looks at the left side of the colon. So the rectum and the descending colon, maybe a little bit of the transverse colon. The fecal test, the fecal occult blood test, stool DNA test. But it's important to note that we like colonoscopy, as uncomfortable as it may be, because it is diagnostic, meaning if there are any issues, we can see them, but also therapeutic. So say there's they find a polyp or something that looks a little funky, they can do the biopsy. If there's a polyp, they can go ahead and remove it while they're doing the colonoscopy. And so there's a decrease in the number of callbacks. If any of these other examinations are abnormal, it's going to be recommended that you go ahead and get a colonoscopy. So I usually tell patients, just bite the bullet. I know it sucks, but go ahead and just get the colonoscopy in the first place. Please be mindful that this every 10 years is for the average risk person. If you have any other issues, genetic mutations, you have known polyps or whatever that were a problem, any other issues, you will most likely have to get this done a little bit more frequently. And honestly, I'm just going to tell y'all, these stool tests you do at home, I don't know about you, but it doesn't sound very, it sounds kind of nasty, scooping up your own stool and putting it on little cards, putting it in, barrels and buckets and whatever else they want you to do to send your stool sample in. That's nasty, y'all. That's just my personal opinion, though. So again, it's easy for the patient, though. And the good thing about them is that they do not require time off from work. They don't require preps, doesn't require that you change anything with your diet. I will say that with colonoscopy, if you're on aspirin or blood thinners, for example, you will have to have a conversation with your physician regarding the safety of stopping and restarting these drugs. And also, one thing to keep in mind for the fecal occult blood test, for patients who take a lot of iron, for patients who take aspirin, things like that, those medications can alter the results of the test and possibly give you a false positive. And also, a lot of these tests that you do at home and mail in are on time constraints. And so if you wait, they say get this in by 2 to 3 days, and you wait 4 to 5 days, it can actually alter the sensitivity of the test. So certain things to keep in mind as you're doing the at-home kits. So this kind of concludes the basic conversation regarding the cancer risk, screening tests, signs and symptoms. I do want to do a shameless plug for Northside Hospital. The Northside Hospital Cancer Institute is absolutely fabulous and fantastic. And I work with so many amazing physicians who take great care of the patient, from other breast surgeons to colorectal surgeons to, the thoracic surgeons. If there are any issues, please go to this website. It's very comprehensive. Or you can call us at the call center at the following number, 404-531-4444. And of course, this information will be available to you even after this presentation is over. And then regarding my cancer support community family, they have so many valuable resources that my patients have taken advantage of rather. And they are so kind and so supportive and provide everything, whether it's a support group, whether you need some stress exercise and you want to learn some new exercises that'll help you stay healthy, education programs, nutrition. They have a test kitchen. They do so many different things for the community, and they are absolutely commendable. And so I want to say that there are resources available, and they can be found at the following website, cscatlanta.org, or you can look for them on Facebook at Cancer Support Community Atlanta. Regarding you and how you manage your health, I think knowledge is power. Knowledge is always power on so many levels. And so a part of having power and getting your power back is knowing what you're up against. There are so many patients who don't know what's going on in their families. And for some people, they can't help it. They may have been adopted, or they just don't have living family, and so they don't know. But for those of you who have the blessing of having your family around you, dig into your family history and kind of figure out what's going on, and if there's an increased risk or something that you should probably have a conversation with your family about. Every time I give a talk in the community, I implore the men and the women in the audience to have an honest discussion about cancer with their families, and make sure that their family's doing what they're supposed to do to take care of themselves, and come up with a plan together. Make sure they get that mammogram, make sure they get that colonoscopy, make sure they just go to the doctor in the first place to ensure that everything is okay. Try to exercise and eat healthy as much as possible. Like we mentioned earlier, I know that there's so many factors that play into the ability to do that and do it safely, but if you can, please do it. And of course, quit smoking. And at this time, I want to give it back over to Emily, open this conversation up to questions to everybody, because I'm sure that you have some. And I want to thank you for participating. Thank you for having me. Thank you for listening to me. And I look forward to answering your questions.
Thank you, Dr. Gore. That was a fabulous presentation. You bring such an important voice and a passionate voice to this material. So I'm so grateful that you were available to do this presentation today. Thank you. So we do have some questions. All right, so first question, as an African American who has survived 2 occurrences of breast cancer, I have had people outside my race ask why more African American women die from breast cancer. Is this accurate assessment, and if so, why?
Oh, it's totally accurate. And like I kind of mentioned during the presentation, I think a lot of it has to do with access. And I think a lot of it has to do with having somebody that's going to advocate. I've had patients who, it seems like they have it all together, and you end up finding out transportation is an issue or cost is prohibitive. And so a lot of these organizations have programs to help women where cost is very prohibitive. But that's a fair question, and it's absolutely right. African-American women are more likely to die. I think a lot of it has to do, even outside of dealing with, cost, transportation. Oh, my doctor didn't offer it to me. We have more advanced disease, and we have more aggressive disease. And it's very unfortunate, but that completely contributes to our risks of death, to be completely honest. And so I don't know how we fix it. I'm still trying to figure out how we fix it, but there is active research going on. And every day, even for triple negative breast cancer, which is considered a very aggressive tumor, new drugs come out and new research studies are being done that give us hope.
Thank you. Next question, what are your thoughts on why African American women are most likely to be diagnosed with breast cancer at an advanced age?
I think advanced stage has to do, I won't lie, I've dealt with some patients where some of it is just sheer denial, and I've dealt with it. It's heartbreaking. I dealt with it in my own family. I had an aunt pass around this time last year from metastatic breast cancer, and it was almost like, if we don't admit that it's there, then it's not a problem. It's not a thing. And so on top of denial, I know the church is very important in my community, in the African American community. It's very important to me. God is going to heal me. Well, yep, yes, he is. But he also gives us doctors as vessels to do that. And so one of my little things, I love going to churches and speaking to women about breast cancer risk, and what to do. But then again, once again, screening. And after you actually get screened, following up with results. There's always a lag time for whatever reason in the African American community on so many levels. And I think that absolutely contributes to advanced stages and contributes to mortality.
How much does having a family history of cancer play a role in the likelihood of being diagnosed with cancer? And if my family member was diagnosed with colorectal cancer, am I at a greater risk for developing any type of cancer?
If you have colorectal or breast cancer in your family, you are certainly at an increased risk, and that needs to be explored. And even talking about, okay, so when do I start my screenings? It may mean you're not necessarily waiting until you're 45. Maybe it means you get a baseline screening at 30 or 35. Of course, if there is a compelling reason to do genetic testing, and nowadays it's so widely available with everybody trying to figure out their ancestry, and with so many of these ancestry companies kind of delving into the healthcare realm and also checking for other things. And so some people are getting this information and they weren't necessarily looking for it. But certainly if you do any kind of genetic testing, or somebody in your family does testing, and something turns up, that absolutely should be explored. You yourself should consider genetic testing, and you should also speak to your physician about what surveillance looks like for you. Like I said previously, I have several women in my practice where every single woman in the family has developed breast cancer. It's scary. It's absolutely scary. But every last one of them have done genetic testing and it's all negative. But clearly there's something going on a genetic level that's increasing this family's risk and causing them to develop breast cancer. And so for those people, they get put on an enhanced surveillance schedule, regardless of the fact that their genetic testing is negative.
Okay, and do you think people should continue to schedule screenings if during the pandemic, the COVID-19?
Oh, Lord, what a loaded question. Personally, I think, okay, short answer, yes. Yes, I do. I think that, and one thing we're learning and one thing we have to come to grips with is that life doesn't stop just because of COVID-19. I think that we take precaution. Obviously, if you're sick, you've been exposed, whatever, then guess what? That screening mammogram needs to wait a few months until things are a little bit better. But in general, I don't think, even in the midst of a global pandemic, people have other real issues going on. And so, yes, I do believe that screening should be going on with the appropriate measures if the screening locations are able to keep up with them and provide care safely. That's the caveat. I don't believe in doing anything in an unsafe manner.
Do you have any thoughts on why there's a disproportionate number of African Americans being diagnosed with this virus?
I think some of it is completely uncontrollable. For example, we're more likely to live in urban areas. We're packed on top of each other. Even if you look at New York and certain areas like Brooklyn, I lived in Brooklyn, and you have certain housing projects and tenements or whatever where you have a large number of people, or people who have to continue to go to work. They can't afford to not go to work, or they're considered an essential service, whether that's working in a factory or working in the grocery store. And so there are certain things you just have to do. I know that for my family, the overwhelming majority of my family is blue collar. I'm the only physician in my family, and they have to work. It's very important. And so I think some of that life things that you can't control certainly contributes to the risk. But I also believe that a lot of the other things that increase our risk for developing these cancers and other chronic diseases also contribute to our risk of developing coronavirus as well.
Mm-hmm. How do I know if a clinical trial is right for me?
First, I think it's so important for African Americans and other people of color to participate in clinical trials. And so I think, especially after cancer diagnosis, I think it's so important to ask about that when you meet with your surgeon or you meet with your medical oncologist. But also, each one has certain criteria depending on the type of cancer you have and depending on what the study is for. And usually our medical oncologists, and certainly our ones with the Northside Hospital Cancer Institute, are just, these people are top notch. And so they usually know what's going on way better than I do as it relates to clinical trials. I'll just be completely honest about that. So asking them, what do you think about clinical trials? What do you think that I should participate in one? Do you know one that would be right for me? And again, remember, there are rules to clinical trials. So just because you say I'm on board, that doesn't necessarily mean you'll be in the treatment group. You may be in the control group and possibly get a placebo. And so that is something to be mindful of. And when they go through the risks and benefits of participating in a trial, then they'll go through that with you. And that's something that's important to understand. But having a very honest discussion with the medical oncologist, and also remembering that, things are so different now in 2020 versus the 1960s. And so I don't ever want, my people of color to feel like they're being experimented on or anything like that. And at any point, one thing you also have is consent, and you have agency over your body. And so if at any point you feel uncomfortable or you don't want to participate anymore, guess what? It's your prerogative. You can do that. And so I think these are things that are important to keep in mind.
Okay. A few more questions submitted. Yeah. What are your thoughts on dyeing your hair or straightening your hair and its connection to cancer?
So this is a very interesting, and when these reports came out earlier in the year, one thing to note that these were not done as a clinical trial. There's been association, but not necessarily causation, meaning people who use these dyes developed it, but we can't say for certain that the dye itself caused it. I think it's important to note that, I just don't believe in a whole bunch of toxins anyway. And so relaxers for my Black women is so important. I won't lie. Got mine going right now. Got mine going. But dyes, and constantly using the dyes, especially the permanent dyes, they can potentially increase your risk. And I know that right now more research is going into that because, again, hair care is so important in the Black community also. So it's something to be mindful of. And if you can minimize it or use natural dyes or use temporary dyes, which seem to have less of a risk of increasing your likelihood of getting cancer, I think that's important. That's my thoughts. I think that more research is needed, but I think that the information we currently have is very compelling, especially considering how important hair care is in the Black community.
Are you familiar with embolisms to address liver cancers? And if so, what is the survival rate?
So it's done. I haven't done liver cancer surgery or liver transplant in a few years now that I'm all breast. But yes, that is one of the treatments. The larger the tumor is, obviously the harder it is to control it, and it may require additional treatments. This is typically done by interventional radiology. And of course, as you know, most of these treatments, while it targets the malignancy, it also has the potential to target healthy tissue. And so the risks outweigh, sometimes the risks can outweigh the benefits. And after a certain point, a discussion is sometimes had about liver transplant and whether that's an option for you. I know there is a size cutoff, and obviously your overall health and what your labs look like plays into that. But have I seen it work in some people? Absolutely.
Is there a link between lung cancer and smoking marijuana or hookah?
So I will be completely honest when I say that I am not sure about marijuana, but do I believe that smoking of any kind increases your risk? Absolutely, I do. I'm gonna be completely honest about that. I know that hookah is very popular, vaping is very popular, and we make excuses for it and say, oh, it's just, the water from the hookah is gonna dye everything down and it's not bad and it's just the flavor. Well, guess what? It's still smoking and there's still nicotine involved. And so if you do that long enough, often enough, it will increase your risk for developing lung cancer in the future. Absolutely.
Okay. What are the side effects of radiation for cancer treatments?
It depends on the location. If we're talking specifically about breast, because we're targeting something that is outside the body, those side effects are usually a little bit more tolerable than it would be if somebody needs radiation to other parts of their body. I know that radiation for colorectal cancer is particularly painful, and it can be a lot for patients, to be completely honest. And those patients experience pain, discharge, obviously damage to other organs is possible. It's very difficult. Decreased appetite, things like that. It can be very painful, especially for rectal and anal cancer. For breast cancer specifically, a lot of the changes, because the breast is outside of the body, a lot of those changes are skin changes. So patients may experience darkening of the skin. Sometimes the skin peels and it can be dry or wet depending on how the patient reacts. I know that I work with wonderful radiation oncologists within the Northside Hospital Cancer Institute, Dr. Zhang, Dr. Simon, Dr. Posser, Dr. Wiggers, and all of these people do a fantastic job of skin care during treatments to make this palatable for the patient. The skin changes do improve over time usually. If you have swelling of the breast because of radiation, that's completely normal. If you have skin thickening, that's completely normal. You have to also be mindful that what sits underneath the breast, you have your ribs, you have your lungs. And so in the future, if you have rib pain, that's completely normal. The heart sits on the left side. So for my patients that have left-sided breast cancers, do know that there's a small risk of exposure, radiation exposure to the heart. We try to minimize that as much as possible. And then radiation pneumonitis is also very common. So scarring of the lung tissue, because the lung does sit underneath the chest wall. And if that happens, that usually presents itself as a cough as well. And if that a dry cough, and it usually goes away with the dose of steroids. So those are some things to be mindful of with radiation. And some of the risks are about the same for lung cancer as well, for breast, since they're all in the same area.
Okay, you are getting a lot of love in the chat box. Some patients of yours just expressing their appreciation and saying how wonderful you are. So I'll definitely share all those with you. I won't read them off now, but thank you for everybody who's been sending that for Dr. Gore. One last question about someone with a history, a family history. My mother was diagnosed in 2003 at age 50 with breast cancer. The same month, my maternal aunt died of cervical cancer. Later, my mom was diagnosed with thyroid cancer and bone cancer. She's now in remission and has what we know to be metastatic breast cancer. I am 40 and been getting regular mammograms since I was 25 and had a BRCA test. What other tests should I undergo to help with any detection?
So I would do enhanced screening for you. If you were to come into my practice and I saw this history, I would be doing MRIs and, mammogram, ultrasound, and you alternating every 6 months. But one thing for people to keep in mind with the genetic testing is that we have different panels. So if you're specifically concerned about BRCA, you can get a genetic test and it will only look for BRCA1, BRCA2, and those very common genetic mutations associated with that. And then you have the extended panels where we're looking at every single gene. And so just being BRCA doesn't mean anything to me, especially if you haven't done testing for the other ones. So specifically when I see thyroid cancer, breast cancer, well, we have that's Cowden syndrome. It's not common, but that's a genetic mutation with the PTEN gene. And it does increase your risk for thyroid cancer and breast cancer. Bone cancer specifically can be associated with Gardner's syndrome. It can be associated with familial adenosis polyposis, FAP syndrome, which is a genetic mutation in the APC gene. And we also see breast cancer in a percentage of those patients as well. And so if she hadn't had full panel testing done, I would ensure that there aren't any other deleterious genetic mutations on some of those other genes that we know increases our risk of cancer. And I would also do enhanced screening regardless. of whether the genetic testing was negative or positive.
Okay, thank you so much. We've gone well over our designated hour. Thank you so much for taking the extra time. I really appreciate to answer all these questions. That was very kind of you to take time out of your schedule for this. Anything else that you would like to say?
Thank you for having me. I'm so proud to be, associated with Northside Hospital Cancer Institute, and of course, my new relationship with Cancer Support Community. All of these people are top notch. And obviously, if any of you have any questions or concerns, my office information was there, I believe, but I'm with North Atlanta Breast Care, which is based in Forsyth, but I operate out of Forsyth and Atlanta. And if anybody ever needs me, I'm easy to find on social media as well at Ryland Gore MD. So I'm so glad to be here. And I thank you for all of your amazing questions and for taking time out of your schedule to listen to me today.
All right. Take care.
Bye, guys.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org. Or follow us on Facebook. We'll be sharing additional information on upcoming programs.